This is Health UnaBASHed, broadcasting live on Healthcare Now Radio. Health UnaBASHed is a conversational platform where healthcare meets innovation. We engage top industry talent and dive into the heart of health and wellness from vision to business model to bring you the latest developments in health tech to promising AI applications, policy, and ultimately impact on the public's health and well-being. I'm Gregg Masters, co-host and executive producer, and I'm joined by the digital health aficionado himself, author, editor, global thought leader, and in his executive capacity, steward servant Gil Bashe. On today's menu, we are in the company of Stefano Bini, MD, professor, UCSF. Dr. Bini also curates the DOCSF, the Digital Orthopaedics Conference in San Francisco, celebrating its 10th anniversary this year. We discuss the challenges of implementing transformational change or redesign in U.S. health systems writ large. With no further delay, Gil, the mic is yours.
Gregg, thank you once again for the gracious introduction. And we have a very special guest with us this time, Dr. Stefano Bini, who is with the UC health system. He's a noted surgeon there. We're going to get into this. This is not the first time that Stefano has been with us. Actually, this is a rare second visit conversation. And what was really incredible about our last conversation that also you set up, Gregg, and I want to thank you for that, is that we were speaking to Dr. Bini from the floor of Health Without Vowels and really doing sort of a lifetime assessment of his take of the conference and his work there with thought leaders throughout the health system. This is an opportunity to grab Stefano, Dr. Bini, in a more private setting. He's actually at the hospital right now. He's running to a clinical meeting right after our conversation. He's been in clinics all day with colleagues and patients. For those of you who are not familiar with Dr. Bini, I strongly recommend you go right after this program or while you're listening to it if you're not driving, and Google his name. You will be beyond impressed with his quiet achievements. And I think Dr. Bini really defines the concept of lions don't need to roar. He's accomplishing so much. And yet I feel the need to bring him back onto the program so that he can, I think, do a little bit of appropriate chest beating about what he's up to right now. I will say, because you're listening to us, that Dr. Bini has decided to follow my good advice. He's grown a beard. And I think if he gets a Life is Good cap and their support, the look of Dr. Bini with the hat may mean I can have a stand-in from time to time from the program. He's looking, shall I say, that dashing. Dr. Bini, welcome back. Stefano, welcome back to the show. Last time we spoke, you were really immersed in looking at how do you elevate the awareness of physicians in terms of the patient experience. And I just want to throw out a premise for you. I don't want to put you on the spot, but obviously it's called Health UnaBASHed. I'm supposed to put you a little bit on the spot, but comfortably. Sure. I sometimes think that the health system doesn't center around the patient at all. Well, doesn't really center around the patient. It centers around the system, and that the system is the customer of the health system, not necessarily the person who the system is seeking to help improve or bring back to a healthy state. I'd love to get your philosophy around that, because I know you're so immersed of trying to improve the system for the patient experience. Do you think there's some credence to that feeling?
You know, let me tell you instead a parable that I heard while I was traveling on my sabbatical in India. And it goes something like this, and it'll make sense while I come back to this. It says, if a man sees a scorpion that's drowning in a river, it's his responsibility to save that life, to bring that scorpion out of the river. And if the scorpion stings him, can't get mad at the scorpion. It's doing its job, right? In some ways. And if it jumps back in, you just do it over and over again. You can't go against nature. Hospitals, especially the private ones, have overlords of some sorts that require them to make a profit. At the end of the day, they are accountable to deliver care, but only to the extent that financially they can survive. Now, you're talking about a high end of that, how much of a profit is appropriate. We're in a capitalist environment. But even in socialist environments, those hospitals given a certain amount of money, their job is to make sure they're open the next day. Let's just leave that as an assumption. So it is our job as clinicians, as people working in leadership in these healthcare systems, to make sure that the patient doesn't get forgotten in this equation. So digital technology and all the work that you and Gregg and I have been talking about, and all your people who have come on board to talk about health and healthcare, have to remember that. They're not the enemy, they're a partner. Problem is that they have certain incentive structures which are not necessarily aligned with those of the well-being of the patient. You can argue the same is true of physicians in a fee-for-service structure. That said, that is to my thing. How do we rephrase, reformat, restructure the conversation so that the patient does come back to the middle, or at the very least gets as much out of the work that we all do as the system does? So to me, it can be a slippery slope to get into this. Well, the system doesn't take care of the patient. All they're worried about is themselves and their stockholders, shareholders. Like, yes, that's not necessarily inappropriate. How do we realign those resources, those efforts to meet? And I agree with you. There's certainly lots of examples where that may not be, or might even be not just borderline, malaligned, and how the incentives can lead to unnecessary procedures, unnecessary testing, unnecessary resource allocation across the whole. So this is what we're in a very interesting place in healthcare, because the digital transformation of healthcare has done a number of things. One of them is to shine in a very bright light in very dark spaces. And that is what the system hasn't liked terribly much, because sometimes you can find that there, in those dark places, there's some seriously malaligned incentives that enrich some and don't enrich others. All right. That said, if you look at the whole healthcare system as a whole, we talk about 30% of unnecessary resource allocation work that's either duplicative, unnecessary, or just simply not indicated, that could be taken out of the system, put back into healthcare, or put it back into the economy. Why I say it's a very interesting time, and one of these very bright lights with tech, is that now we can finally figure out, and it's just starting to come to maturity, which is something that those of us have been on this front line have been saying will happen eventually, but people will be kind of like, hey, when is it going to happen? I think now we're starting to get to the point where some of these data sets that we're actually being able to make sense of are starting to show us how we can identify those resources and reallocate them correctly. So if you look at where AI, artificial intelligence, which really is artificial intelligence, machine learning, is really working quite well, is in resource allocation, identifying those areas in the healthcare system where we are misallocating resources. Another way to look at it is not so much misallocating, but reallocating to be more efficient, more effective.
Let me jump in for a second. I think first of all, you've answered that incredibly diplomatically. Since you're sitting right now in the health system and you don't want people, it's not a live broadcast, but if it were, you don't want all of a sudden people pounding on your door saying, quick, muzzle him before he says anything else. And you've been very thoughtful about this. I recently wrote a piece about health kinetics. And in this piece, I talked about the fact that we're constantly looking for a villain of who's responsible for both perhaps inadequate care or disparities in care or cost of care. And I said, the reality is we're all a little piece of the problem. But the challenge is that it's not that the patient is the, quote, should be at the center of care. Because I think that we often say the patient is king, and I would say I'm not really so certain about that. I think the patient is there too. The system is the system's best customer. You point out correctly that that's the case because the system has to survive the way that it's structured. It has to survive. So in this piece on health kinetics, which is the relation of pieces to pieces, I talk about the fact that I think you as a clinician who's passionate about what you do. You've studied all around the world. You have really an academic pedigree, and I think you passionately do care about the people who are under your care. I was wondering, would the system be well served if it said it's not that the patient is or isn't at the center of the system, but how do we look at all the pieces as they relate to the outcome that we seek for the patient? If the patient has a better outcome, patient costs us less. If the patient has a better outcome, they're healthier for the future. If the patient has a better outcome, we've put them on the right course of action, whether it's physical therapy or medication therapy or surgery or whatever. If the outcome is better for the patient, then obviously we're no pun intended for you as a surgeon, but we're operating more effectively. So maybe I'll rephrase the original question and let you also think about the response, which is, are we looking at the pieces, or when we deploy augmented implementation, AI, I call it augmented implementation, but when we deploy the technology to sort of streamline and act in a more effective way, what's the center of our activity? Is it just looking at activity, or is it looking at trying to make a difference in the patient experience and the outcome that we all see? The patient, the provider, the payer, the policymaker, you. What's the center of our goal?
It's time for me to interrupt you because you're throwing too many variables into this equation for me to give you a reasonable answer.
Okay.
But let me look. I like the idea of health kinetics, and kinetics is maybe kinematics, maybe, but either way, the idea of these things moving relative to each other, how do you orchestrate them to optimize their outcome? That's the basic question. So here it gets to a question: whose outcome, or
Right.
whose version of the outcome?
Right.
And then the other question, the second question is, how do you measure that outcome? So the problem we have when you're looking at these, putting on my systems hat, having had multiple leadership,
I appreciate that.
is if you want me to optimize a system, you got to give me something I can measure to optimize against. Otherwise, it's just value-based optimization, which could be religious-based, or it could be societal-based, or if I get you back to work, is that better value to make you happy? If I get you back to work, is that better value than giving you longevity as a result of my treatment? So you have to start saying, so I'm going to put it back to you. So what exactly do you want me to optimize for? Health is kind of tricky question to answer. What is health? It varies. If you've got chronic diseases, health is just keeping those things neutral, so you can still stay alive. If you don't have any diseases, health is being healthy, it's being normal, it's being 20 years old again. So this is a matter of a challenge. When we try to be reductionist about health systems and health care, and it's 1/5 of the US economy, and come up with something that's simple for us to understand, that we get stuck with the idea, with ideas that sound good on paper. But when it actually comes down to implementing it and giving to people to fix, it's like, how do you solve this problem?
Just dropping in, you're right on time for Health Unabashed on Healthcare Now Radio. Today we're chatting with Stefano Bini, professor, UCSF, Arthritis Joint Replacement, Orthopaedic Institute, and founder and chair of DOCSF, the Digital Orthopaedics Conference in San Francisco. Do follow Dr. Bini's work on the web at www.docsf.health or www.orthosurgery.ucsf.edu, or on Twitter by SBINIMD or at the DOCSF. Stay tuned for the rest of the story.
I think that's a reasonable sort of like question to begin from. I love that how you brought it to the question, because I don't think we really have answers here. I think that we need intelligent questions, and you've just raised one, which is, my belief has always been we have to stop looking for the villain in the equation and start realizing we can't tear apart the health system. We can't say, okay, let's just shove it out the window and build it from anew. Now, we're in a system, but we have to also understand that we're trying to create a better outcome for people. Now, in this country, I think we spend about $4 trillion on health. 11% is on pharmaceutical products. I think 52% is on hospital systems, providers, and so forth. And the rest is on, I guess, stuff. And I'm not saying even get rid of the stuff. I'm not even saying reduce the $4 trillion. I think that you've raised a question, which is, how do we get people to align that we want it to be better? So that kind of lets me pivot over to what you've been up to lately, because you're very passionate about leaning in and creating conversation, education, a sense of awareness in the professional community. When we last met at Noisy Health, on the floor, on the exhibit floor there, and the booth that was created for us, you were very active. You had a number of things that you were up to. Can you give us any updates on your, not in the operating room, advances, but how you're advancing the conversation with your colleagues?
So I will put that. So actually, I'm very active in the surgical side. I just launched a society specifically for the purpose of taking some of these questions about challenging the standards of care out of the system, because the system didn't, in my opinion, have the infrastructure necessary to be able to truly question it. So I actually built a society outside of that to look at one specific problem, which is knee alignment surgery, and the personalization of care, trying to focus on back to the patient, no longer just the surgical piece, but the entire patient experience. And that society is going well, and it's going to allow us to leverage all these technologies to put into, and also some of it's not even technology, a simple, better methodology to improve the care pathways. So that's one part of my world. And three things which are worth talking about. My conference, which Gregg has been to before, is now in its 10th year. We're launching the month focusing on this year on robotics and AI, but not today's robotics, the future of robotics. I'm always trying to get people to see what's going to happen, because we kind of know what will happen because we can see it elsewhere, but let's bring it into their visual field so they can start processing and get ready. But what I've learned is that we're now moved my personal opinion, in these type of conferences, move from the discovery phase to the implementation phase. So rather than having a bunch of keynotes about the future, I got rid of all those, and it's 50% hands-on, small group discussion sessions on how to implement stuff. Whether it's getting your staff to not be afraid of AI because they won't be replaced by them, or whether it's understanding what a VC will want to fund, or what a hospital system will buy and why. Get it down to small group sessions. So that's my conference. And then behind that is going to be my latest project, which is stealth, but not so stealth. I'll tell you about it. But we're very interested. All my work I did for the last 5 years with Google, etc., we didn't publish a whole lot, because at the end of the day, we're learning about what we're doing. And I didn't get a bunch of stuff that we're publishing. But what I did learn is that I could, for the first time in history, based on the use of super expensive sensors, edge computing, and the cloud, tied to modern algorithms, a little bit beyond basic machine learning, is actually measure how people move in space, which means that we may have, for the first time, the ability to develop a biometric for health writ large, because it's hard to argue that one of the ultimate outcomes that all can agree on for all healthcare is keeping people moving through space, whether it's your back, your hip, your neck, your lung, your heart, whatever. It's all designed to say, if we can find a way to be very specific and very sensitive about changes in mobility, and then tie that back through large data sets to different disease processes, we might, for the first time, be able to say, hey, if I have an NIH grant, how am I going to measure the outcome? If I'm investing in something, how am I going to measure an outcome? If I'm a hospital system and delivering care, how do I measure your outcome? And we're working on that. It's super stealth, very small group, super well organized. We're very excited. We have a vision. We're going to test it. We're going to run it like a startup. Kind of quiet. Fail quickly if we failed, but if we're not, we're going to come back to you in a year and tell you that we've solved a really key issue for pretty much all healthcare. Is we don't have a single metric that we can all agree on that's reproducible, scalable, inexpensive, easy to obtain. Very cool stuff. Super cutting edge and simple at the same time. So that's my big project right now. The other thing you might be interested in.
I just want to say that, and we'll get back, but that kind of really touches on the first question that you and I were exploring, which is, what are we trying to get at in terms of an outcome that's meaningful for all the participants around that patient's experience and care? I mean, you've just touched on that, which is, let's define a common outcome, in the community. I think that's brilliant. Now, keep on going.
The other thing, and just in a quick thing, is I just came back from a 6-month sabbatical. So that never happens in my world. People won't take 6 months out of their productive life and take a financial hit to go travel the world, which I did with my amazing wife. And we traveled around the world. And the thesis of my travels was that the future is here. It's not evenly distributed, a phrase that I borrowed. And I would go around and call people and say, listen, fortunately, I'm fairly connected. Then people would call and say, let me talk to somebody who's driving change. And what I was able to do was interview and speak and spend time with these incredible people who have spent their life innovating and driving improvements in healthcare in their various systems, whether Australia, New Zealand, India, the Middle East, all the way over to pretty much every country in Europe we visited. And he had an opportunity to, I thought I'd get a sense of what the healthcare systems were in each of these countries, but you'd need a year in each one to do that. What I got instead was extraordinary perspective in how different people have navigated their worlds to make a change. And I'll tell you, I'm going to create a series of podcasts because these people's voices truly need to be heard. They're remarkable. And what they taught me was the importance of perseverance, the importance of having a vision. But the one thing that I hadn't read in all the leadership books that I've read is the importance of curiosity. Each of these people had at their core real curiosity. They asked questions, they had ideas, they had thoughts, they were willing to challenge themselves. They weren't stuck necessarily in what they were thinking. They often had circuitous routes to how they got to where they got because they kept asking questions. And it was an absolutely phenomenal experience to have that opportunity and to spend hours with them in some cases in context. So in other words, not over Zoom, but literally in their offices where they were working, where they could say, well, you see that building, this thing, et cetera. And to me, that was really eye-opening, instructive. And I think as much as with many of your guests, when people listen, you're inspired to do better. I walked away from this thinking that if anybody ever tells me again that it can't be done, if I can avoid laughing at them, I say, no, it's not that it can't be done. Maybe you can't do it, but it can't be done.
It's fascinating. I was really struck by what you said because I was speaking to people on Monday in another country and talking about my own life trajectory and what keeps me vibrant and at the top of my game. And I said curiosity. I said I'm constantly wondering what is the next, and I'm constantly striving to look around the corner, to peek around the corner and the next corner, and that has kept me particularly relevant. And I find that people get very rooted in the here and now. Now, this morning I was speaking to probably someone you know well. Gregg knows, he's been on the show a few times. John Nosta,
yes,
and John Nosta and I were talking about a topic. He's talking about the cognitive age, and we were talking suddenly about curiosity. Now, Stefano, you bring up curiosity. I don't think that's ever by accident at all. I don't believe in accidents. I think coincidences are just things we haven't really figured out distinctly the connection. But I think that what I would respond to is you and John and Gregg and others. I think that we're so passionate about the well-being of people, and we're so prepared to continue to push forward and against the gravitational pull of the here and now, the status quo, that we're curious about what could be better for humanity. And I think that curiosity is our fuel. And I think that you are a person of continuous fueled curiosity. Even your sabbatical for 6 months, which I sense came at sure, you can take a sabbatical, Dr. Bini, for 6 months without pay. But you felt that was an investment in the essence of who you are. In the moments we have left, I would really value hearing from you what we have to look forward to from your efforts, but what you think we should be looking at in terms of the health system's evolution.
I think the health system evolution is going to be one of decentralization. I think we went through this centralization process attempting, and now with the power of technology, we can decentralize. Decentralized care is a lot less expensive. The problem is running into is a resource allocation, but also staffing models. There's no the AI will take a job. Whose job are you taking? There's nobody lining up for those jobs for which we're going to deliver AI. It's not like you have an option of a doctor who's well rested, has lots of time versus AI. No, you have the option of nobody or AI, or possibly an overworked nurse or AI. But if you're outside, 30, 40 miles outside San Francisco, the Bay Area, you're not going to get the care that everybody says that they want, but they're not willing to pay for. And B, frankly, can't. It's just too expensive. So decentralization of care, I think, is one. The other is, I think, was to get away from two things. One, the idea that the healthcare system is broken. It's not broken. There's nothing broken about it. Is it doing exactly what it was designed to do in the 1940s by the health systems, insurers primarily? And it is working. It just is not working the way we want it to work. That's different. So we have to rethink the delivery model. So I don't agree with you that the delivery model can't change. But within the delivery model, there are many variations thereof, some which are working very well. And so what you're going to see is that just because it is a relatively free market, you're going to see these systems that are more effective, more efficient, are able to generate revenue while delivering care and scale themselves, be very successful. The one thing I did just leave with this third concept is the mid-sized hospital systems. So what's special about them? The very large hospital systems are very much have a problem in the technology world. And you and Gregg will probably agree that they have inertia due to their existing tech stack. It's very hard for them to move up in the food chain. The very small hospitals don't have the wherewithal or the funding, or perhaps they're small because they're a rural hospital. They just don't have what it takes. Those mid-sized hospitals, generally speaking, are newer. They don't have as big of a legacy problem as the others have. And therefore, we'll be able to change quicker. And that's our clock.
First of all, thank you. That he'll edit that out, not to worry. He'll edit this part out also. But thank you. Now, Dr. Bini, I did hear you the last time at Health, although it was very noisy. It was insightful. It was incredible. It was, most importantly, I think one of your greatest gifts to the health community is your practical mindset. You're not looking at this as so far futuristic that we can't grasp it. You're talking about what can we do going forward. I want to thank you for joining us again. I'm looking forward to a third conversation, wherever it may be in the world. Gregg, once again, thank you so much. And to our listeners, keep listening in. Thank you all.
And that, dear listeners, is the last note for today's melody. A huge thank you to our worldwide audience for tuning in. And tip of the hat to our special guest, Stefano Bini, professor, UCSF, Arthritis and Joint Replacement at the Orthopaedic Institute. Do follow Dr. Bini's work on the web at www.docsf.health or Twitter via @SBINIMD or @the_DOCSF. Health UnaBASHed streams live 3 times a day on Healthcare Now Radio, Monday through Friday at 10:30 a.m., 6:30 p.m., and 2:30 a.m. Eastern, or 7:30 a.m., 3:30 p.m., and 11:30 p.m. Pacific. Stay social with Gil and me on Twitter by @Gil_Bashe, and that's BASHE, and Gregg Masters, MPH, and that is Gregg with 2 G's. And don't forget to give your tweet some zing with our hashtag HealthUnaBASHed. Until we meet again, pursue your passion for better health and with no apologies.